Wonderful. Good afternoon, everybody, and thank you all for being here. I want to start with the question we're going to keep coming back to. How do we improve health outcome for people living with both HIV and Hep C who don't have stable housing? Not how do we screen more people, not how do we document better, but how do we get someone cured of hepatitis C, virally suppressed from HIV, and still in care a year from now when they don't have a place to sleep tonight? I'm Lawrence Benson with the Corporation for Supportive Housing, or CSH. I'm a senior program manager on the national consulting team, and I'll let my co-facilitator introduce herself.
Hi, good afternoon, everyone. My name is Maya Saxena. I use she, her pronouns. I am also a senior program manager here at CSH, also on the national consulting team. Happy to be here.
So we want to be clear and upfront with you all around who we are and what we bring and what we don't. We are not a co-infection, in clinicians. So we're not here with all the clear clinical materials, but what we do have, we have exactly those guidance that I'll be citing and that we'll be reading from. So when we get to housing and how to get paid for it, that's the part that I do on an everyday basis. So I work in the intersection between health and housing, and that's where I'll be able to elevate. Maya also works in those intersections between health and housing, as well as she has experience working with direct services. One more thing, and I'm not going to read these slides to you, but you'll get them afterwards. And what I want you to do is to walk through how these pieces connect together, because that's the part that's the hardest to pull out of a resource packet. We really want you to take some really good information around the integration between these two and how important it is with housing. Next slide. So for some housekeeping, quick logistics. So you're all muted. You can use the Q&A panel throughout, drop questions when they come up, and we'll get to them as we can. You can also put them in the chat. Hopefully one of us will be able to watch when we're going off and stop and interject if there's any questions that come up. We are recording, and the recording and the resources go up on the CSH technical assistance page. Captions can be turned on and on. And there's an evaluation at the very end. We'll ask twice because it shapes what HRSA funds next. Next. So here are your formal objectives for this. Here's what we mean in practice. By the end, you should be able to explain to a colleague why housing isn't a side issue in this work. It's a clinical variable. You should be able to name specific changes to your screening workflow that would find more people. You should know why the guidance says not to wait for someone to be housed or sober before you treat. And you should know who to call in your own community to build the housing side. The last one is the piece that I hear most often. Teams know what good care looks like and have no idea who to call. So why does this matter? These three numbers right here. The CDC reported that in 2022, 83% of people newly diagnosed with HIV were linked to care within a month. The Healthy People's 2030 target is 95. About 39,000 people were diagnosed that year. So we're moving slowly, and there's a real gap. One caution about that, 83%. You'll notice that I didn't say the gap is worse for people who are unhoused. National HIV surveillance doesn't break linkage out by housing status. It's probably true, but I can't source it. So I'm not going to say it. And I ask you not to say it either because it ends up in somebody's board presentation to look pretty. What we can talk about is where things break down. It tends to be in three places. People never get tested, or they get tested and never get the results, or treatment waits after diagnosis, and people fall out of care after they start. So we go back to this slogan, and you'll hear us repeat it over and over this presentation. Find them, treat them, keep them. That's how we've organized this next hour. For the agenda here is for the next hour. The first, why outcomes break down, the landscape, and what the data can and can't tell us. Then the longer stretch on finding people and treating them. Then housing, which is the keeping part. We'll hold time for questions and close with resources. There's also one point in the middle where I'll stop talking for about 2 minutes and ask you to think about your own organization. That one's worth your attention. So please, uh, participate when you can. And I'll pass it to Maya.
Thank you, Lawrence. So, segment one, we're going to start with the landscape. And just to be straight with you, parts of this evidence are thinner than people would assume. I'd rather you leave knowing where the ground is solid and where the ground isn't as solid. So, a question that has come up a lot is what is the co-infection rate? People want one number for a grant application. They want to have one nice, strong number. And the answer is there isn't a current national one. You'll see 21% cited all over the place, including on this slide. It comes from adults with HIV who were tested in 2009, and the CDC labels it that way. And the issue isn't this figure, it's that it gets repeated without date attached, and then it reads as current when it's really not. This is what the evidence does support. CDC data shows injection drug use is accounted for 6% of US HIV diagnoses in 2023. Among people who inject drugs and are living with HIV, US studies report hepatitis C antibody rates anywhere from about 11% to 71%. In specific outbreak clusters, it's run as high as 70 to 94%. And that is quite a spread, right? Look at that spread. 11 all the way up to 71. And that's not bad research. That's the finding. Co-infection risk depends so much on who you serve and where that a national average wouldn't tell you much about your own patients. And that's the practical point, and it's going to come up a couple of times today. The number that matters for your planning is yours. If you go back and pull your own co-infection numbers from your own records, that's worth more than anything that you're seeing on this slide. So, what do we know about housing and risk? We know homelessness and unstable housing are linked to higher HIV and hepatitis C acquisition among people who inject drugs. That is well supported. The big one is a Lancet Public Health Review from 2021, and you can say that without hesitation. What you shouldn't do is give a specific multiplier comparing sheltered and unsheltered people. You'll sometimes hear things like, unsheltered people are 3 times more likely, and the evidence doesn't support a universal number like that. Effects vary a lot depending on what services exist in the community. And the variation is the useful part. It means risk isn't really a property of someone's housing status, it's housing status plus their environment around them. Two people sleeping outside in two different cities can face very different risk because one of them has a syringe services program 8 blocks away and the other person doesn't. Now, our own data. The Uniform Data System, or UDS, is what health centers report into every year. In 2024, health centers reported about 217,000 patients with an HIV diagnosis and about 113,000 with a hepatitis C diagnosis. And you'll notice that HRSA reports these two separately. The national totals don't tell us how much they overlap, and the national totals don't include housing status. So the group this whole webinar is really about, which is people with both conditions who also don't have stable housing, isn't really something that the national data set can show us. The UDS is built to capture diagnoses across the whole program, not to link conditions at the patient level. So that number isn't one the national data set produces. It's one that you're going to need to build locally. So let's get concrete about how this actually breaks down. It's easy to say housing instability is linked to worse outcomes, but it's more useful to say how. Think about what our treatments require. Somewhere safe to keep a bottle of pills for 8 to 12 weeks, a way to get to an appointment on a specific day at a specific time, and a way for us to reach you when a lab result comes back. And every one of those points quietly assumes a permanent address. And I'm just going to give y'all an example here for a little bit more context. This isn't one person, it's a pattern that people describe. Someone, let's say, comes to a mobile unit, they get tested, and is reactive for hepatitis C antibody. The team tells him to come back for the confirmatory test, and he means to, but his encampment gets swept, his phone gets stolen, and the clinic's number was only in his phone. 6 months later, he shows up in an emergency department with a skin infection, and nobody there knows about the reactive test he did 6 months ago. He didn't fall out because he didn't care. He fell out because the workflow assumed he'd have a phone and a permanent place to sleep. So, what we're saying is the response can't be housing or treatment alone. It has to be both, because each one covers where the other fails. So this slide splits up what we're up against in two columns. On the left, it's structural, housing costs, fragmented service systems, payer and prior authorization barriers, transportation, uneven access to harm reduction. And on the right are individual, active substance use, behavioral health conditions, injection practices, treatment fatigue, and survival needs that outrank everything else on any given day. Here's why we put them side by side. Most clinical training points us at the right column: assess the patient, change the patient's behavior, improve the patient's adherence. And that instinct isn't wrong, but if you only work on the right column, you'll watch good programs underperform, and eventually people will start believing that the problem is the patient's, when it isn't. The left column is still there. Programs that work push on both the right and left columns. And this is really the case for integration, and that is what our next segment will be about. Quick scale check. In 2024, about 1,350 reporting health center awardees served more than 32 million patients. That is the actual size of this system. And one note about what's not on this slide: an earlier version had a national count of patients screening positive for housing insecurity. We actually took this out because we couldn't confirm a current comparable figure in the 2024 data that we were going through. And that was our call-in building this deck. And I'd rather tell you than show you a number that we can't really stand behind. And I'm saying this out loud because it's the standard, and we'd ask you to hold your own program data up to that standard as well. It's easy to build a good story on a number that we don't really know if it holds up. A little bit more on the case for integration. So let's put it together. When HIV care, hepatitis C care, substance use treatment, and housing all sit in separate systems, somebody has to navigate between all of them. In a fragmented system, that somebody is the patient. So we've handed the hardest coordination work to the person with the least to work with. The research, and there's good PLOS, or Public Library of Science Medicine Review from 2021, that shows that integration generally improves testing uptake and treatment initiation. How much depends on the model and the setting. Bundled screening, warm handoffs, closed loop referrals, each remove a place where someone can fall through the cracks. On cost, and we'll be honest, cost effectiveness depends on your local workflow and your staffing and your payer mix. It isn't just an automatic ratio that we can assume. But here's the principle underneath it. Housing stability supports treatment. It should never be a requirement for treatment. We don't make people earn hepatitis C care by getting housed first. So a couple key takeaways: pulling the thread. Housing instability is linked to higher acquisition risk, and it breaks the specific mechanics treatment depends on. National linkage was 83% in 2024 against a 95% target. And the national data can't see the group that we're here talking about, which is why your local data is the place where it becomes visible. We spent 12 to 14 minutes on why this is difficult, right? Let's spend the next 20 on what works. So segment 2, This is the practical part. The first half is about finding people. The second half is about treating them without delay. So a couple guidelines first. Quickly, the U.S. Preventative Services Task Force recommends screening adults 18 to 79 at least once for hepatitis C, and that's a grade B recommendation. And then testing outside that range when the risk is higher. The CDC recommends testing all adults at least once and during every pregnancy. For people who inject drugs with ongoing risk, we repeat that once a year. Now, two design choices that matter more than the guidelines because they're what turns a policy into a result. The first, bundle HIV and hepatitis C testing together. Opt out. Opt out means the test is just what we do here, and then someone has to decline it. Opt in means that somebody has to raise their hand and identify themselves as at risk in front of staff in a place where they may already have felt judged. The CDC's compendium found that this reframe increases uptake in syringe services and other low barrier settings. Second, antibody testing with reflex RNA confirmation. Reflex just means the confirmatory test runs automatically on the sample you already drew. There's no second visit needed. Think back to that composite. His care ended in the gap between the reactive antibody test and the confirmatory test he never was able to come back from. Reflex RNA closes that gap for everybody without anyone having to remember. Okay, where people fall out. Here's an example workflow that you can adapt. You'll see on the screen we have entry, substance use treatment, screening, treatment, and housing referral. And I'd say don't look at the boxes, look at the arrows in between that connect the boxes. The boxes are things that your organization probably already does. The arrows are where people disappear or get lost. This is where most losses are in these transition spaces. Screened but never got the result but never started treatment but never got connected to housing. Another example for you all. A clinic mapped their own version of this, and they found their worst arrow was between the reactive screen and treatment start. About half of reactive patients never began. They made one change. The community health worker who did the intake became the person who owned that handoff and stayed with the patient through the confirmatory result and the first treatment visit. It's not a new program they created. It's not new money that anyone found. It's just one person who took on the responsibility for one arrow. And that's really the takeaway from this example in this slide. You don't have to redesign the entire pathway or have your organization do 10 brand new things. Find your weakest arrow and put a name on it. Okay, let's name some of the barriers because you'll come across them. The big one is the belief that you shouldn't screen or treat someone who's actively using. The American Association for the Study of Liver Diseases and the Infectious Diseases Society of America guidance is unambiguous here. Current or recent drug use is not a contraindication to hepatitis C treatment. And that's the guidance, and it's worth quoting directly when it comes up at your own site. Second, stigma and distrust, which are usually earned. A lot of patients have had experiences in healthcare that have taught them to expect judgment. Person-centered, trauma-informed communication isn't really a soft skill here. It's how you get that second and third visit. And third, time and staffing, which is the argument for building testing and reflex confirmation into the visits that are already happening instead of creating new ones. And fourth, billing and authorization rules vary by payer and by state, and then they change. And we want to verify those and not assume. So who carries the navigation burden? There are two ways to structure integrated services, and I judge them by one simple question. How much navigating are we asking the patient to do? On the left, you'll see co-located model. Co-located means HIV and hepatitis C services, substance use treatment, and housing support are all under one roof. The patient is walking through one door. That's the whole string. The burden moves from the patient onto the organization where it belongs. It costs capital and staffing, so it usually fits the larger health centers. On the right, you'll see a coordinated model. Coordinated means formal partnerships, shared data, closed loop referrals. Lower capital cost, but the coordination work is real, and somebody does have to own it or it will decay. It often fits better with smaller and rural sites, but it can work well. Both are legitimate. What doesn't work is the third option nobody picks on purpose, drifting into a coordinated model where nobody actually owns the coordination part. And that's really just fragmentation with a nicer name of coordination put on top. Whichever model you pick, staffing decides whether or not it'll work. These teams are multidisciplinary. They are clinicians, community health workers, care coordinators, peer specialists. The important thing on this side is ownership. Somebody owns screening, somebody owns confirmatory testing, somebody owns treatment start, somebody owns housing referral. And when programs underperform, it's usually not that nobody was working, it's that everybody assumed another person had responsibility over one of those arrows. We want to train for person-centered care, harm reduction, overdose response, motivational interviewing. And note that the slide says illustrative. This isn't a required national standard. We want to build it to your own context. And Lawrence, I'm passing it to you here.
Thank you. Because that was finding the people. Now, this next part is about what happens after we find them. And the good news is, according to the American Association for Study of Liver Diseases and the Infectious Disease Society of American guidance, most uncomplicated adults can be cured of Hep C with a simplified oral regimen in 8 to 12 weeks. Cured in a field where we manage a lot of chronic disease, and the word deserves more attention than it gets. On access, things have improved. As early 2026, 34 states Medicaid programs had dropped prior authorization from most patients. Sobriety requirements, rules that, someone prove abstinence before treatment, were eliminated nationally in 2024. Both of these are a point in time. State policies move. Verify where yours is before you rely on it. And this can happen in primary care. You don't automatically need a specialist. Check interactions with HIV and antiretroviral therapy, refer the complicated cases, and don't make specialty referral the default because every referral is another arrow. Which kind of brings us to a barrier that probably caused most cures than any policy on any slide today. It's us. The belief is that someone actively using can't finish treatment. Here's what the evidence says. Early data analysis in people who inject drugs and opiate treatment cohorts found pooled cure rates around 88 to 90%. Cure is sustained virologic response, no detectable viral load 12 weeks after treatment ends. Many real world cohorts report about 95%. And the difference between those figures is mostly retention and loss in follow up, not whether the medication works. That reframes the question. It was never whether this patient can be cured, it's whether the program keeps the connected long enough to finish. That's a design problem, and design problems have solutions. For example, I'm going to do this as a composite you'll recognize. A patient with active stimulant use is seen, and the plan says treat Hep C once he's engaged in substance use treatment and more stable. Sounds reasonable. He doesn't come back in 4 months, and when he does, it's a different provider and the workup starts. 18 months later, he still isn't cured, not because the treatment failed, but because it never started. The 8-week course he could have finished at the first visit would have been done in 2 months. So treat current drug use as something that shapes how you deliver care. Flexible dispensing, peer navigation, low barrier follow-up, not as a reason to exclude someone. Adherence without an address. So how do you support adherence for someone who's unhoused? Practically, medication storage, offering options that don't assume a locked drawer, follow up, flexible scheduling, outreach, transportation help, low barriers, and labs. And remember that behavioral health needs, food, the personal safety are competing for the same attention you're asking someone to spend on a pill. And the line that anchors this: don't delay antiretroviral or help see treatment until someone is housed. Housing, support, and treatment run at the same time, not in a sequence. And there are so many health benefits for getting someone virally suppressed, both for Hep C and HIV in the beginning stages when they are first infected. So, two guardrails worth noting. You'll see, and we're on slide 24, four guardrails on this slide, but two we're actively covering: offer testing and treatment regardless of substance use or housing status, and read your outcomes in context because your patient mix shapes your number. Let me spend the time on the two that are new. First, use integration to reduce handoff, not to create a new eligibility gate. This happens, a health center builds a good integrated program, and then it becomes a program you have to qualify for: intake, screen, waitlist. You've added a door where you meant to remove one. Second, track your steps separately. So testing, confirmatory diagnostic, treatment starts, completion, referral closure. When those collapse into one number, you can't see which arrow is failing, and you will spend a year improving the wrong thing. I'm going to stop talking for 2 minutes, like I said before, because the person who knows your health center best is you, not me. Picture your own pathway where screening happens, where confirmatory test happens, where treatment starts, where housing referral happens. Then answer one question: which arrow fails most often where you work? Not the whole system, just one of those arrows. And is there one change you could actually make that you could put your name on it? Not the ideal change, just the one that's possible. So I'm gonna give you all just a couple minutes to think about that. And I invite anyone, if you are here, to put it in chat, or if you want to put it in Q&A, you're more than welcome to. In my experience in HIV work, most of the arrow that failed was between the screening and the confirmatory test. Getting someone back in there was the hardest for us to try and figure out how to navigate that system. And what we did was exactly what was here. This was at Cobden Square Community Health Center here in Boston, Massachusetts, which was we attach someone to that number. We had a peer navigator and a medical case manager who were attached to those patients who came there, and they screened. Even if you weren't at work, you would get a page saying you have a new patient. This is starting. You need to make sure that you're in place when they start, because it's so important. We'll go ahead and keep going to the next slide. Whatever you came up with, here's how you know if it worked. Because a change you can't measure is one you can't defend when the budget conversation happens. So track screening offer and completion rates, and be specific about the denominator and the time period. That's where the number stops being comparable between clinics. Track confirmatory testing and linking. Track treatment start, completion, and cure. And track housing referral closure, not the referrals made, referrals closed. Those are different numbers, and only one means anything. One caution: same as before, write up your lessons before your data is verified, after your data is verified, not before. And I say it again: write up your lessons after your data is verified, not before. Some takeaways from this second segment: three things. Build screening into visits that are already happening. Opt out. and with reflex confirmatory. So finding people doesn't depend on anyone remembering. Don't delay treatment for substance use or housing status. The guidance is clear and the delay is the risk. And whichever model you pick, put a name on every arrow so we can find people and cure them. That leaves that third break, and it's the hardest, keeping them. Here's the uncomfortable part though. We can do all of that well and still lose people. Someone cured of Hep C who's sleeping outside can be reinfected. Someone virally suppressed without a place to live is one disruption from an interruption. Um, which brings us to this last part. Housing, name it. Sorry, go to the next slide. We'll name it. Um, and this is your material. You can speak with more confidence here than anywhere else in this deck. This is the keeping part, and it is what I do. The model exists, how to match them to people, how they get paid, and who to call. And I want to keep things, I want to keep tying things back. Every one of these is ultimately a clinical intervention because it decides whether the treatment we just talked about holds. So on this slide here, we're talking about different models. There isn't one kind of housing and difference aren't paperwork trivia. They decide who you can refer and how fast. Permanent supportive housing is permanent housing assistance plus supportive service for eligible households. That includes someone with a disability. That isn't time limited. That is a service, and that the services are voluntary, which means because voluntary, it's what makes people work for people who have been mandated into things their whole lives. There's recovery housing. Recovery housing is a recovery centered, substance free place to live with peer and professional support at different levels. There's rapid rehousing. Rapid rehousing is a permanent housing with short or medium term rental help and services, generally up to 24 months. It builds to move someone out of homelessness quickly, not to support them indefinitely. And the line at the bottom is the one that hold on to. Eligibility, tenant protection, funding, and service intensity all vary by program in place. That's true if your county may not be true for the county over. So it may be here in Boston, but if you go down to Worcester, it's not the same. Which is why the next few minutes are mostly about verifying instead of assuming. On slide 30, matching, not maximizing. Here's how to think about matching. Higher acuity or long-term homelessness plus significant clinical need generally point towards permanent supportive housing with ongoing support. Moderate acuity may point towards rapid rehousing, and low or variable need may be met with affordable housing and lighter support. Two things I have to say clearly. This is an illustrated aid, not a national standard. There's no national acuity matrix that determines placement. Your actual placements run through local coordinated entry. That's the process where community uses and access and prioritize people by housing and through each program's own rule. And the principle is matching, not maximizing. When you care about patients, the instinct is to push for the most intensive option, but permanent supportive housing is scarce. Every placement that didn't need that intensity is someone else needed more. Matching will is how a sacred resource reaches the right person. Now, that piece I was talking about, how do you get paid from it? So how do you get this funded? Medicaid Section 1115 waiver demonstration are the mechanisms to know. Each 1115 is a waiver that lets a state test something Medicaid won't normally cover. These can authorize certain housing related services for defined groups, housing navigation, one-time moving costs, tenancy support that helps someone keep their unit, medical respite, sometimes short-term housing assistance. What's approved is state specific, and newer proposals are being reviewed case by case. You'll notice that there are no number of states on this slide. That's on purpose. Any count I've gave you would probably be wrong by the time you acted on it. So instead of a number, here's a habit. Before you rely on a benefit, check Medicaid.com, .gov, sorry, your state Medicaid agency, and the KFF waiver tracker. Those three together will give you your current answer. That habit will outlast any slide on here. So again, that's the Medicaid.gov website, your state Medicaid agency, and the KFF waiver tracker. Those are three to always go to if you're questioning what can be covered by a benefit. Let's sharpen that because this slide has more immediate consequences for a real person. Approvals aren't uniform. That covers varies. Who's eligible varies. Start date and expiration dates vary. California is one document example of a state who with approved short-term rental assistance, but that that's an example, not a list. And you shouldn't conclude anything about your own state from it. Review has also moved toward a case-by-case approach in 2025 and 2026, which means older summaries date quickly. As an example, why this matters, here's another composite. A care coordinator tells a patient genuinely trying to be helpful that Medicaid will cover his move-in cost because she read that somewhere. Turns out her state approval covers navigation, but not move-in costs. He'd already given up the shelter bed he had. The benefit wasn't there, and neither was the bed. And the next time somebody from the clinic tells him about a program, he didn't believe it. He wouldn't believe it. That's the real cost, not the paperwork error, it's the trust. So here's the most concrete thing I'll ask from you today. Before you tell a patient about any benefit, you check its availability. Three sources, 5 minutes, said, let me confirm that and get back to you instead of, yes, that's covered. Maya?
Thanks, Lawrence. So we're not saying today that you need to go off and your organization becomes housing developers. You all don't need to be developing housing. You have to build the relationships that get your patients into it. So here's the answer to the who do I call question. And the thing I said at the top that teams most often don't know. We want to start with your local continuum of care or COC. That's the group that coordinates homelessness planning and funding in your community. And it really is your front door. If you take one action from this segment, find out who runs yours. There's always one person who's kind of overseeing all of the coordination of the COC. From there, your public housing authorities and whichever voucher or preference programs apply. And then also check with your state housing finance agency or HFA. And then jot it down, write it down, roles, consent, data sharing, closed loop referral protocols. How do these entities work? I've watched really strong partnerships fall apart because the one person who made it work took another job, or they left and they moved on. Formalize it while that relationship is still good, and it can outlast just one person's employment. The people who make this work day to day are community health workers, peer specialists, and care coordinators. They assess housing needs, connect people to various resources, and follow up, which is where most referrals live or don't live. Peer specialists with relevant lived experience build trust faster than clinical staff often can. And it's not just a soft observation that I'm making, it's a retention mechanism. Two things decide whether the role works. Training has to cover local eligibility rules, tenant protections, privacy, and practical navigation, not just engagement skills. And define role boundaries, supervision, and escalation before you launch. An unsupported CHW or community health worker holding a complex case is being set up to fail. And that's a program design failure, not a CHW failure. So I'm going to bring it together a little bit. Screen, diagnose and treat, assess housing, link to housing, and sustain the engagement. And I think Lawrence mentioned this earlier. A shorter version is find them. That's the screen part. Treat them. Diagnose and treat. Keep them. And that's the last of these three. So find them. Bundled opt-out screening built into visits already happening with reflex confirmation so nobody falls into those gaps. Treatment. Don't wait for sobriety or housing. Keep them. Treat housing as the clinical variable that it is. Link to the model that fits through coordinated entry and hold it with follow-up and closed loop tracking. And you'll notice here at the bottom, every step needs a defined owner across clinical, behavioral health, harm reduction, and housing partners. No one provider owns this whole pathway, which is why it falls apart. Not from bad intentions, but from everyone reasonably assuming, right, that somebody else is holding one of those arrows. Okay, so we have a quick poll for the folks who are still in the room. Andrea, if we could launch the first poll. We want to hear a little bit about what's the biggest barrier your health center faces in connecting this care with housing services? The options are lack of housing resources in our area, staff capacity and training, data systems and referral tracking, funding and sustainability, or maybe other. And I don't, oh, Andrea's back. Do you mind? Oh, thank you so much. Okay, so that should be popping up on y'all's screen and we'll give it a couple minutes. Okay, 2 out of 2 so far, lack of housing resources in our area.
That's a very big thing, the lack of housing
Mhm.
resources in the area. It's also one of the things that also is could be is can be true and not having a directory, not being a part of that industry. I've seen health and housing be so disconnected, and there has to be some type of bridge that you have in order to connect that information. So there could be some resources, and there could be no directory where you can go and just find that, especially on the state website, unfortunately.
Mhm. Oh, that's super common. Housing resources are so variable that by the time you make a directory, you need to make a new one.
Yeah.
Okay, so we're swinging significant lack of housing resources in our area. And like Lauren said, that definitely tracks. It's also about getting connected with that front door of the homeless response system, which is going to be your continuum of care. If they aren't accessing those resources, they're going to be happy to bring you in so that you can tell them what you know. And they really are your front door to housing and homelessness. We got one funding and sustainability. That's interesting.
Mhm. I think I hit the wrong. I'm going to relaunch it because I think I hit the end button too soon.
Oh, no worries. Well, I know that we had 3 and 1. And while you're thinking through that, I am gonna push us towards a couple of resources, just to keep us on time here. So places to go, and like Lauren's mentioned, you're gonna get a copy of these slides, so you don't have to hurry to write these down or anything like that. But we've got AASLD, the American Association for the Study of Liver Disease and Infectious Diseases Society of America, for current testing and treatment guidance, including for people who inject drugs, the CDC for surveillance and clinical resources, HRSA UDS for health center data, CMS and KFF for that 1115 tracker. And that's that verification habit that Lawrence was mentioning earlier. Definitely check first. And then we've got SAMHSA's findtreatment.gov and recovery housing guidance. And again, all of this will be provided to you with the recording. And then thank you all for sticking with us. Let me move this forward. Andre, if we could launch this evaluation, it'll just take a minute, very, very quick. It includes the BIPIT common questions plus some items that were specific to today. And it really does shape what HRSA supports next. So it's a really good opportunity to share your feedback. And especially tell us if there was something that you needed today and you didn't get in today's session. I'll pause here for a moment. Awesome. As those are coming in, I will push us to our thank you. We just wanted to say thank you for spending this 50-ish minutes with us today. Thank you for the work that you do for patients who are really the hardest to reach and the easiest to lose. And if there's one thing that sticks, we hope that it's this. Things break down in three places. People never get found, so we want to build that opt-out screening with reflex confirmation into visits you're already having. Treatment waits. We don't want to wait for sobriety or housing because the guidance is clear and the delay is really the risk. And people fall out. So treat housing as the clinical variable that it really is. And go a little plug, go find out who runs your continuum of care if you don't already know them. One more time, find them, treat them, keep them. Thank you all very much. Lawrence, anything to add?
Just if you are looking for who to figure out what your state does for a waiver on CSH's website, we also have a tool, as I mentioned, on the Medicaid.gov or your state ran Medicaid program. We also have a tool on the CSH website that breaks it down using a map.
Perfect. Thank you all. Have a good rest of your day.
Bye bye.